Welcome, students. We are now getting started in this second half of our Chapter 5 lecture. So we're going to finish out the entire PowerPoint this session. Where we left off is we were looking at pet food and considerations with our dogs and cats and feeding requirements. Now we're going to move into looking at nutritional support for patients that are hospitalized and how we can give nutritional support for certain medical conditions and how that looks different in the hospital. So, in our first slides here, we're looking at nutritional support for debilitated patients. So these are going to be hospitalized patients. They could be hospitalized due to traumatic injury or illness or post-surgery. There may be many different reasons why they might have to be hospitalized. So we know that good nutrition can help counteract the immunosuppressant effects of any medical or surgical condition. So if we're feeding them good and they're getting their good calories, they are getting their essential and non-essential vitamins, minerals, energy producing as well, they're going to be in a better spot with wound healing. They're going to be a lot more energized and able to heal themselves faster from illness. Their immune system will respond quicker. Their metabolism is going to be stronger. Versus if we can't feed them or they don't have that good nutrition while they're healing, that's where we can find really long healing times. And we'll talk about it in the next few slides, what we will do if the patient's not eating enough and how we can help them through that. So we like to keep them on their normal food when they're in the hospital. Like if they've had surgery or a traumatic injury, we usually will give them their normal food that their owners feed them from home. There's no real reason to switch it up unless they're not eating. Um, and we need to start feeding like critical care food that's just way more caloric dense. That being said, if the patient's in the hospital because of an illness, we're hospitalizing them again because of some kind of illness or disease, absolutely going to be putting them on some kind of prescription diet, especially for critical care that's going to have a lot more vitamins, nutrients, minerals, everything that they need to heal and hopefully support their body to get better, minimizing their hospital stay. Now, if a patient's hospitalized, we're going to reassess them every day. The doctor is going to reassess them, looking at things like their weight history. We weigh them every day they're in the hospital. We also will look at like the nutrition history. Again, sometimes it's best to just keep them on the food that they've always been on rather than doing sudden changes. We always like to do gradual changes, but again, if the patient's not eating and we're in a position where we might just offer anything and everything to see if they'll eat, sometimes it comes down to that. Now, if we have offered them everything, they're turning their nose up to it, they do not want any of the food that we've been offering, the patients have to eat. They cannot get better if they're not consuming calories. So we may have to give nutritional support during hospitalization. That might be necessary. And we're going to look at that through the next few slides, what that might look like for patients. We can start with giving like oral supplements. It- there's it's an oral supplement. It comes in a tube and it's called NutriCal. And it is a super calorie and vitamin packed paste that you can give dogs and cats when they're severely ill and hospitalized and are in need of calories. But if the patient can't eat, let's say they have a jaw injury and their jaw is wired shut and they cannot eat, we're going to start to look at other routes of administration for food. We're going to look at feeding tubes, enteral tubes, and parenteral tubes or nutritional supplementation. So, with that being said, in order to know what they might need, it starts with monitoring everything, right? Watching their appetite, watching their daily excretions. If they're eating and drinking, they should be urinating and defecating, right? So if they're not doing one of those things, something's wrong. We need to address that. Those can often be overlooked. Now, of course, if they're not meeting their nutritional requirements, they will lose weight and they might not heal or get better as quickly as they could. So, again, we will offer them food. If they don't eat, we're going to offer them anything and everything. We might even try an appetite stimulant. The most common one that we use is called metrazapine. Um, we're usually giving appetite stimulants to cats. Um, they do make metrazapine in a transdermal form, which means it comes in like think of like a neosporin. Like it comes like as in a little ointment, and you just put a little dab of it right on the inside of their ear flap, and it soaks in to their skin, and you don't have to give them pills. It's amazing. I love it. Transdermal medication, if you've never heard of it, it's fantastic, especially for cats or any patient that has a hard time that you have a hard time giving pills to. So we'll try an appetite stimulant. If that doesn't do the trick and the patient still isn't eating, or like I had given an example, maybe their jaw is wired shut, they physically can't eat, we're going to explore other routes of administration. So this could be an enteral tube, which is feeding tubes, and we'll talk about the various types of enteral tubes. It could be a parenteral route of administration, which means it's through an IV catheter, usually right through a major vessel in the body, which is the vena cava, that's right in the heart. Or it could be a combo of a feeding tube and IV nutritional support. So let's talk about first enteral tubes. So an enteral tube is a tube that's there's a few different ways that we can place it. It just means that it's a tube that we're going to place to give nutritional support to this animal. So this little kitty cat that you see here, it looks like might be waking up from surgery or sedation, got some eye lube on. We do completely anesthetize them when placing feeding tubes. We do for this one, this nasogastric, the one that goes through the nose, that one could be done under sedation. But if it's going to be one that's in the pharynx, that's absolutely going to be a full-blown anesthesia procedure. But let's walk through the different types here. So the first type of feeding tube, and one that's fairly common and one that we'll actually teach you how to do as an assistant, is an orogastric tube. That's a tube that you're going to use, one like that you see here. This is called a red rubber catheter. We also use these as urinary catheters. They have multiple purposes, but commonly use a red rubber catheter as a feeding tube. So orogastric is when it goes through the mouth, down the esophagus, and into the stomach. Again, you more than likely will get training on how to do this, especially if you work at an emergency hospital or in a hospital where they do ICU critical care of hospitalized patients. We do orogastric for puppies or neonates, brand new puppies, fresh out the womb, usually C-section babies, because we need to get them that colostrum and that supplementation right away, and mom might still be waking up from anesthesia. So orogastric, again, taking that tube, going through the mouth, down the esophagus, into the stomach, and we can give them a supplementation of milk. We don't tend to bottle feed them when they're brand new, neonates, they're brand new babies. It actually is a lot safer to do the orogastric tubes. We don't have to sedate them for this either. It's minimally invasive. And it's very easy to do. Even a breeder at home could do this with their own puppies if they needed to. And a lot of them do. We train owners how to do this, especially breeders, so that if they have a runt of their litter that's not gaining weight fast enough, they could do the feedings at home. So orogastric, usually it's short term, just used to give food to puppies. And you would place the tube, give the milk, and then take the tube right out versus the one that you see here with this cat. This is called a nasoesophageal or a nasogastric tube. It's the same thing, it's just two different ways to say it. That means naso, it's going through the nose, esophageal, so up through the nose, down the esophagus, which is the muscular tubule that connects the mouth to the stomach, and then all the way down into that gastric stomach. So this, again, is usually going to be done under anesthesia or sedation. And they will place the tube. The doctor will do this. They'll go up the nose and then down, and they'll take an x-ray afterwards to verify and make sure that it's in the stomach and they placed it correctly. Remember, there's two muscular tubules that run down the throat, down the neck. There is your trachea that goes from the mouth and down into the lungs. And then there's the esophagus, which connects from the mouth down to the stomach. So we have to make sure we're in the correct one. You will know if you're in the trachea, the patient's going to start coughing and having a really visceral reaction to it because they can't breathe if you're putting it down the tube that they use for air. Um, that being said, it's a doctor that's usually going to place the nasoesophageal tubes. You'll be assisting with that procedure. We use the tape here to actually suture it to the patient's face. So the tape is around the tube and then we suture it right to them. Again, they're totally anesthetized when we do this. So when they wake up, it's just like having like stitches if you've ever gotten stitches before for any type of injury. You might feel them going in, but once they're in, it's not really bothersome. Again, they're going to be sedate for this, so they're not even going to know. They'll wake up and it's already placed. Now, this feeding tube, it goes around to the back of their neck, and usually it's connected to a collar to hold it in place. And it'll have a little cap that goes on the end of it to stop any flow after the feeding. This tube, nasogastric tubes, can be used for long-term use. So as you can see, they're using a big 60 cc catheter tip syringe, and they're going to fill that with wet food and water. Even medications can be given through the tube. I have seen nasoesophageal tubes be used for upwards of 6 months on patients that needed severe nutritional support. Um, this is not a permanent solution. A feeding tube is a tool to help get them the support they need, help their body heal, and then eventually transition them out of the feeding tube. In fact, when we have feeding tubes placed in the hospital, we might even start to offer them food and water while it's still placed. They can still eat and drink while it's placed. And then once they start to eat and drink on their own, we'll remove the tube. Now, that's the less invasive way to do it is the nasoesophageal or the nasogastric. There is a more invasive procedure to do this, and this is more of a, it's kind of more of a permanent feeding tube. We still don't want to keep it in for, years and years. We have to monitor these sites and making sure that they're not getting infected or things like that. But we can do a pharyngostomy, which is a feeding tube that is placed into the pharynx. So what we're going to do is we're going to anesthetize this patient, put them under anesthesia. We're going to shave their neck. The doctor is going to make an incision in their neck and go right into the esophagus, you guys, right into it. Wall of the pharynx, right into the esophagus, and place the tube from their neck into the esophagus and down into the stomach. So they will do usually like a Chinese finger trap type incision, or sorry, not incision, suturing. That's what they call it. And they call it a Chinese finger trap because how they do the incision or the suturing on the incision is when the tube, if it starts to pull, that Chinese finger trap suture that they do will hold it and make sure that it doesn't pull out because that's obviously a huge risk, with it being placed in the neck. Now, this is an open incision, um, so there is risk of infection and there's just major risk with it. But again, if I have a patient that can't use their mouth or has some kind of injury to their face where it's just not an option to do a nasogastric, we could then go and do that one through the pharynx. It is more invasive. Way more risk of infection, but it can be used for more of a long term. A nasoesophageal, you can have it in for a little while, but when we're talking about comfort, it's probably not very comfortable to go up and through the nose. The one in the neck is actually a lot more comfort wise better for them. So I've seen patients that have the tube that goes in through the larynx, esophagus, and down. And I've seen patients that have them for upwards of a year or more. That being said, it's not practical. We don't want to have them on feeding tubes for a long time. But if the owner, wants to do that kind of care and keep their animal alive and give them that kind of nutritional support, who are we to deny them? So we can do that if necessary. Again, we're gonna go for a naso before we go into the pharynx and do like an actual procedure with it, but it's an option. I've seen a lot more feeding tubes placed on cats than I have dogs in my career. Cats can be a lot more finicky than dogs, especially with picking food and as they get older. And so we can do it on dogs, but I will say that for me personally, in my professional career, I've seen probably 90% of feeding tubes were in cats. The e-collar is essential, by the way, the cone of shame that this kitty cat's wearing, and that's to make sure that they don't scratch and try to pull the feeding tube out. If it's on the neck, same thing, we'll have a special cone and stuff to protect it as well. Now, we can also do feeding tubes that are directly placed into the small intestine or directly placed into the stomach. These, again, are for more long-term use. Um, that being said, y'all, I've been in the field since 2010, 2009 almost. Long time I've been in the field, and I have never seen a feeding tube placed directly in the intestine or the stomach. I know it's mentioned. I learned about it in my textbooks when I was in school. I've never seen it done because there's other options that are less invasive than going right into the stomach. That being said, it's not unrealistic that you wouldn't see it. You still may. But we do have other options that are less invasive and that don't require abdominal incisions because any doctor is going to try to avoid big abdominal incisions and all of that if they can. Um, Now, would there be reason to place it into the small intestine or into the stomach? Yes, especially if the patient has certain conditions where that might be more ideal. For example, if there was an issue with the stomach, like stomach cancer, and we couldn't put food directly into the stomach, we could give them nutritional support right into the jejunum, which is in their small or the duodenum, which is in their small intestine. That bypasses the stomach, but it still gives them nutritional support. So that I could see why they would use that. Again, though, if you're not working in oncology, you're probably not going to see that. Um, that being said, they could also do a gastro tube if the patient had a debilitating injury, could not, again, and it was not feasible to place it in any other area. So possibly you would see that in an emergency environment as well. But again, I've never seen it, but it doesn't mean that you won't. Just not as common as the other methods. They're much more invasive, that's why. All right, so now looking at enteral nutrition and their calorie requirements for if we're doing this tube feeding. So we need to be looking at some really big things. If they're on a feeding tube and they're getting enteral support, we need to be feeding them food that is really caloric dense, which means that it's a lot of calories in a small amount of food. So we're usually going to feed some type of prescription diet. We have critical care diets that are prescription that are super packed with vitamins and minerals and all the essentials that they need, super fatty, really high in calories, exactly what they need to get better. So we'll usually use, it's called AD, and Hill's Science Diet makes it. It's one of the best critical care foods on the market and has been for 20 plus years. Um, and that's a great option. So it's a pate, and you need canned food. If you're going to be feeding through a feeding tube, look at how small that feeding tube is. Nothing chunky is going to fit through that. It's going to get stuck. It's going to get clogged. So we are going to use a pate. That critical care food is a pate form. And we might even put it through a blender too, to make sure like there is no little bits that are going to get stuck in this feeding tube or clog this feeding tube. Because if we have to replace the feeding tube, we have to put them under again. And that's a whole nother procedure. We don't want to do that. We want to avoid that if we can. So we'll typically take some of the wet food and we'll blend it with water, because we want them to get more water and we want it to be more liquidy to go through the feeding tube nice and well. The doctor will calculate based off of the patient's weight and based off of what their ideal body weight is. They will calculate how much of the food we need to give and when. Typically, that's like 20 milliliters per kilogram of body weight. So if you think about it, if we had a patient that was 20 kigs, let's say 20 kilograms, so 20 milliliters, so it would be do it 20 times 20. So we would probably give 400 cc's per feeding. Um, Possibly daily. It really just, again, this dose will change depending on are we trying to lose weight, maintain weight, or gain weight. And your doctor will calculate that. We just have to follow the instructions that they give us. So they will let us know how many milliliters we need to give per feeding. We're typically doing tube feedings 2 or 3 times a day. It could be more often if we really need them to gain more weight. We also will be giving them water. We will offer them water in their cage. We're always going to have bowls of water available for them, any animal that's on a feeding tube, but we will be giving them water through a syringe as well, right through that feeding tube. Typically, when we're feeding, we do water first, then the food, then more water to flush it through to make sure that nothing dries and cakes on the inside of that tube to make sure it's nice and clear. Something to consider as you're feeding, this takes a long time. Tube feeding is not a fast thing. You cannot just fill up that syringe and slam them with 60 cc's or, even up to 400. You can't do that even in just one. If it was a 400, probably going to be split into a few different feedings. Typically, it's usually 200 or less milliliters per feeding. Obviously, if it's a really big dog or something, we can adjust that. Um, when you're doing this feeding, right, you're going to give it through this big catheter tip syringe. These are 60 cc's. So you'll have measurements and everything. You'll be able to measure it all. It's going to take you anywhere from 15 to 30 minutes to do this tube feeding. It is a very slow process. If you slam that food into that patient, it's going to come right back up. They're going to vomit it right back up. Their stomach's not expecting it. So we want to feed them slowly and have them be comfortable during this feeding. And you're going to take your time. You're going to sit there and have them in the cage and you're just going to slowly feed them over about a half an hour. We do this again to prevent them from vomiting back up and to prevent any stomach upset or, we want them to retain these calories. That's the whole point of the feeding tube. So we take our time with it. We also need to make sure that the food is mixed well. Again, blending it, usually canned food and water. And then we want to make sure that it's room temperature. So it shouldn't be cold. Like if you got it from the fridge, you're going to want to warm it up a little bit in the microwave. We don't want it to be hot because it's going right into the stomach, but we do want it to be room temperature or slightly warm. Anything that's colder can also cause them to get nauseous and vomit. So we want to be aware of the temperature as well. Now, depending on your doctor and the treatment plan, as the patient starts to get better, we typically will start to offer them food in a food bowl to see if they'll actually eat it. We will not be removing this feeding tube until this patient can prove to us that they can eat on their own and eat enough calories to not lose weight. So typically we'll try to offer that fresh food, and then as they begin to eat, we'll supplement a little bit with that feeding tube, gradually decrease it to where they're not getting any feeding tube and it's all them eating on their own, and then we'll be able to remove that feeding tube. It's different for every patient. I've seen some pets that only needed it for a few days just to get over the hump of like a really massive surgery. I've also seen pets that have it for a few months while they're recovering, and also when it comes to like chronic diseases and management of that, sometimes it's more needed for those type of patients. With feeding tubes, we can actually send them home with the feeding tube in place. That's kind of a really cool part of feeding tubes is they don't have to be in hospital. We can teach the owners how to do the feedings and they can absolutely do this at home. I had a client with a cat that had a feeding tube in for over a year and we taught them how to do it and they successfully did the feeding tube. The cat was going through cancer treatment. And so that was just the best option for them was to have a feeding tube in place to make sure they got the calories. And as soon as they were done with their radiation treatment, we weaned them off the feeding tube. And that cat lived for several more years. It was a really great case. But again, we taught them how to do that at home because as you can imagine, if they had to be hospitalized the whole time they had that tube in, I couldn't even imagine the bill. So it is something that we can train owners how to do and they can manage it at home. The only risk that we run here is that, remember, these can become infected, especially the ones that are placed through the larynx. So if we are sending them home with a feeding tube, we usually will have them bring the patient back in at least once a week for us to examine the site, and we'll teach them how to clean the site and make sure that it is to monitor it and know what signs to look for if there's infection. But it's just like how we can train owners to do subcutaneous fluids at home, feeding tubes, absolutely. Aside from feeding tubes, we do have another type of nutritional support that we can do. This is called total parenteral nutrition, or TPN. I'm going to refer to it as TPN moving forward. TPN is an IV infusion of nutrient solutions. So this is a fluid bag that is packed, filled with nutrients and minerals and vitamins and calories, and it's in an IV bag form. I have worked a lot with TPN, especially with racehorses. As many of you know, a large part of my career was working with horses, especially racehorses on the track. I lived in Kentucky for quite some time. And we would do this TPN nutrition with the foals. That's brand new baby horses. It's common. Well, I wouldn't necessarily say it's common for all horses to go through this, but we saw it a lot in a hospital environment, of course, because they're going to bring them in when they're not well. But we call them dummy foals. So when a foal is deprived of oxygen during birth, or maybe it's a dystocia, it was complicated birth, some kind of birth complications, the foal can be born with limited mental capacity. So that foal might not be able to stand. It might not be able to nurse yet. And we call them dummy foals. This is not uncommon, especially if you're in working in hospital with horses. I saw it so much. And they either pull out of it or they don't. I would say it's probably 50-50. It just depends on how long they were deprived and how severe it was. Most, again, 50-50. So some foals will pull out of it within a few days. The other half will pass away, and they'll never it will they will not be able to sustain life. So the reason why I'm talking about dummy foals is because we don't place feeding tubes in dummy foals. We will give them TPN because that is one of the strongest forms of nutrition that we can give them directly in the bloodstream. And when they are in that mental capacitated state, they're not going to be able to suckle on a bottle. We could place a feeding tube, but we're not even sure if their stomach's digesting well. Again, we don't know how significant the damage is. They'll either pull out of it or they won't. So the best way to get nutrition to patients that are like that, like fully debilitated, is going to be through IV. So we're going to place, it's not an IV catheter. We'll actually be placing a central line. So think of it as like a super advanced IV catheter. Um, and I'll be talking about that more throughout the next few slides. But this is something that we can use again for patients that need that nutritional support who are not a candidate for the enteral support for feeding tubes. Now, it can be used in small animal medicine. I have seen it used in certain emergency cases. Some doctors prefer it over feeding tubes, but be aware, and I will preface by saying this, TPN is expensive, really expensive. It's probably upwards of $1,000 a day for a dog or a cat. With horses, I think we were billing almost $5,000 or $6,000 a day for TPN. And mind you, the horses that I was working with, y'all, they were race horses that had insurance policies that were worth more than me. I mean, millions of dollars of insurance policies on these horses because they're worth so much money. So for them, it's the insurance was paying for it. For them, billing, all this thousands of dollars wasn't really much for them. But again, if you're somebody who doesn't have insurance or, you've got a dog or a cat who might not have super high insurance policy premiums, it can get really expensive really quickly. A feeding tube is much more cost effective, but when we're talking about animals that are worth multi-million dollars and have these insurance policies, the doctors are going to use the top nutrition and care and all of that that they can because they're able to with that kind of unlimited amount of funds for treatment. Um, that was a really interesting part about working with racehorses was that there was almost no medicine that was off limits. We were really able to do almost any kind of treatment as long as it was within the lines of the insurance policy. And I hope to see that transform more in small animal medicine. I would really love to see small animal medicine get to a point that's like that too, where the owners don't have to worry so much about the cost, the insurance has it, and we can do more treatments. Because this is really expensive, but I've seen it work wonders. I mean, there is a reason that we use it. Now, we can also add things to TPN, and you can actually even make your own TPN. I've never made TPN. I've only ever had it come to the hospital already pre-made. And like I said, it's like a milky white color. It's going to be filled with proteins, fats, carbohydrates, vitamins, minerals, water. It's going to have all of that already pre-packed into this IV bag, but you technically can make it too. Again, I've never done that, but I do know that it's possible. Now, we do and can give extra dextrose, which is just dextrose is just a scientific term for sugar. So we can give injectable sugar into this TPN bag to keep them at a good sufficient blood sugar level if we notice that their blood sugars are dropping, which can be a problem with TPN. So we always can give sugar either intravenously. We can always smear some honey or Caro syrup on the gums too to help increase that blood sugar. We don't want to have to add insulin though to bring it back down, so we do have to be really careful about that. But any patients that's on TPN is going to be monitored 24/7. Now, TPN also provides lipids, which is required fat. So, depending on where you get your TPN sourced from, that could be things like it's fats from oils or from egg yolks or glycerol. It just depends on the manufacturer that you're using to acquire the TPN. Now, we do have to monitor for lipemia. This is too much fat cells in the blood because remember, this is going directly into the vein, into their bloodstream. So we do have to really closely monitor these patients. And that's also why it's really expensive because you are also paying not only for TPN, but you're paying for support staff to be monitoring your patient 24/7, doing constant blood checks and blood work to make sure that they are maintaining nutrition and we don't have to adjust anything. Again, they're also going to be getting proteins from amino acids and such that are added to TPN. There's also going to be electrolytes that are added to TPN. So it is a full nutritional supplement, again, that's given intravenously. Now, we can add more vitamins to it or even supplement with like a multivitamin supplement. Most TPN is going to come with everything it ever needs. But I have noticed that, let's say we did blood work and we noticed that a patient was more deficient, like let's say in like vitamin K or B12, something like that, we can always add more vitamins to it or, supplement in some other way by giving a subcutaneous or intramuscular injection of it. Um, Now, TPN can be given ideally for just a few days. If you have a patient that's on TPN for longer than a week, it's pretty rare. I think the longest I ever saw a patient on TPN was a little under 2 weeks. And that patient didn't make it. We were trying really, really hard to get this full to turn, and they just didn't. So typically, these critical care patients will be on it for up to 2 weeks, but it's typically less than a week. Again, we have to factor in cost. If this is a small animal that they don't have insurance policy, we have to factor cost into that and what's feasible, what's affordable. Again, the doctor will be calculating based off of the patient's weight and based off of, again, are they underweight? Are they maintaining? Do we need them to gain weight or lose weight? What's the situation here with the purpose of TPN? We also have to look at what health condition, what's going on with them. Um, Again, so many factors that go into how we're going to dose this. So you don't have to worry about the dosing. The doctor will calculate the dose. Usually it's going to be a certain milliliter amount per pound of body weight. So I was calculating this earlier, like let's say we had a dummy foal, like I was giving you an example of. Foals, baby horses when they're born, are typically anywhere between usually 2 to 300 pounds. They can be a little bit heavier, of course, if it's a draft horse or a larger breed. And that could be up to 4,000 cc's of TPN a day. So if we think about it, one little fluid bag, that's 1,000 cc's. So they would need at least four of them for a foal, for a baby horse. And that's just as at a maintenance rate. They may need more, they may need less. To horses, we typically will give them larger fluid bags, any livestock animals. So when we're talking about large animal medicine, we actually use fluid bags that are 5,000 cc's. So we use the 1,000 for small animals, and then for our big animals, again, a horse can be upwards and over 1,000 pounds. Most of them average at about 12 to 1,300 pounds. They're going to need more fluids, of course, compared to your, 50-pound dog. So everything is bigger in large animal medicine. So 4,000 cc's for a day of TPN, that's not too bad for a foal. So as you can imagine, that can add up really quickly. And that's also why it's so much more expensive with equine medicine with horses, because we're having to use so much more drugs and supplements because they're massive animals. That's also why a lot of owners, when they have these high dollar horses as well, have really good insurance policies on them. I didn't see a single horse at Root and Riddle Equine Hospital. That's where I was working. I never met an owner that didn't have a policy on a horse. That was just the kind of caliber of patients that we were treating, which I loved because again, there was no cost constraints. So this was all stuff that was possible. Now, if you are preparing TPN, again, the odds of you actually putting together TPN, I never have. It always just came already preset and ready to go, and we would add a few things if we needed to. But again, you may be preparing it yourself, and if you are, you want to make sure to follow a really strict aseptic technique. So I would be, using an aseptic hand scrub. I would use sterile gloves. I would be disinfecting everything with alcohol before injecting anything into the bag because you might be needing to add things like dextrose, amino acids, electrolytes, vitamins. You might be adding that to this TPN if it's not already added to that solution. Now, how do we administer TPN? It is an IV catheter, but it's actually a central line. So this is a catheter that for horses, it still goes in the neck. For horses, we always put it in the jugular. Um, for small animals, IV catheters usually go in the leg. If it's a central line, it also goes in the jugular. So know that if we're putting a dog or a cat, if we're doing a central line in the jugular, this patient's probably completely incapacitated or in a debilitated state. So it would take a lot for us to do a central line and do TPN nutrition in small animal. The feeding tube is a much better option, but we do it a lot in large animal. So this advanced IV catheter, let's say, this central line, it goes in through the jugular, but it's got multiple ports and long catheterization that actually connects and goes down into the vena cava, which is one of the largest vessels that goes directly into the heart. You also may know of the aorta, but that's pumping blood away from the heart. The vena cava that's going to the heart, that's what we want the medications going right to that source. So, it is a more advanced catheter. It's called a double lumen catheter, and only doctors place central lines. Technicians don't even do it. So be aware that if you are or a patient has to have one placed, you'll be assisting, you'll be helping the doctor and helping set up and everything for it. We typically sedate patients for central lines because they can be painful. Again, we're placing a catheter that's going super down into those veins. And right into the jugular, which can be more sensitive. So we can sedate for it, or give them muscle blocks and relaxers as well. But it will be a doctor that's going to be placing it and monitoring it. Central lines are like catheters, they can last up to 2 weeks. However, we may need to replace them or replace parts of them throughout. We're constantly going to be monitoring these. They have a higher incidence of infection because we're going right into some of those major vessels in the heart. We always use a fluid pump when we're giving TPN. You're never even going to be doing drip rates and counting drips and things like that. You're always going to use a fluid machine. That way you know exactly what we're giving and it's accurate. There can be complications with TPN. Because of these catheters, these central line catheters, they are at a much higher risk for sepsis and just contamination of that catheter. What can happen if they get infected? It's called a deep vein thrombosis, which is when the vein essentially it just causes a massive infection in the vein, and the vein itself fills up with pus, and it'll stop and block that vessel. Absolutely can cause sepsis and kill a patient. Um, it's pretty intense. I've only seen it on, let me see here, maybe two horses in my career. Um, both cases we were able to save them, and we got in time, but in order to prevent this, it's proper catheter management and keeping watch of it 24/7. And in all honesty, at the first sign of it starting to reject or not looking good, to pull it. Because on one of the cases that I saw the deep vein thrombosis, the doctor's like, let's try to ease it. Let's try to milk this catheter. And then boom, the patient got a massive vein infection, which took them weeks to recover from. So when in doubt, pull it out, we replace it. Okay, before we get into our next portion of the lecture here, we are going to take a small break. So I am going to pause the recording now. All right, students, welcome back in from your break. So we are now getting started in the kind of second portion of tonight's lecture, which is based off of now common animal diseases. So we're going to do a little bit of review for the last few slides here, getting back into things like terminology, talking about immune response, zoonotic diseases, vaccination, preventative medicine, predisposition, for medical conditions. We're going to summarize all of that here in the last portion of the lecture. So, again, getting into common diseases and also talking about zoonotic. So, zoonotic means that a disease can spread from animal to human or human to animal. So, we're going to talk about the methods used to control the spread of these zoonotic diseases, what you need to be aware about with zoonotic diseases to protect yourself and your patients. Again, we'll look at underlying disease prevention, vaccines, schedules of vaccines, which has been a big topic of this module. There's an entire vaccine PowerPoint that you can find linked in week number 1. Please go download that if you haven't already. It's a full overview of dog and cat vaccines. And then we'll summarize with predispositions to disease and what to look for in your pets. So as we get started, we're going to look at common diseases, response to those diseases, breaking that down a little bit more. So starting with some terminology here, a disease, the definition, it's known as any alteration from the normal state of health is what a disease is to be considered. Now, we have veterinarians that actually specialize in pathology. Pathology is the study of disease. So these would be a veterinary clinical pathologist. That is a veterinarian that has gone through 3 years of extra residency with exams and extra materials, and they have to pass more board exams to then become specialized in pathology. So again, that's going to be a step up from your general practice vets because they've done more residency. They have a higher certification in some type of specialty field. In this instance, with pathology, these are veterinarians that work for labs. These are veterinarians that assess lab samples, biopsies. They give results and interpretations of these results. And that's what then they send back to the general practice veterinarian who ordered the test, and then they give the results to the owner. So pathologists have a really huge role that they play in veterinary medicine to help give us valuable information regarding causes and prognoses of diseases. Terminology that might be used by pathologists are going to be things like gross lesions, when we're talking about taking like a punch biopsy or doing any type of biopsy or cytology, we might look at things like where was the location of this taken, what's the color, size, texture, and appearance of this altered tissue. They also look at things like morphologic diagnosis, which is usually limited to describing the lesion within that organ system. It might even be etiologic, which is causative diagnosis, and that's what's the cause of this lesion. So when you start to work in the field, you will get the opportunity to read through these pathology reports, and you'll want to. You're going to follow your patients and their cases. I know that that was something I always liked to do was, wow, what about that dog from last week? I wonder if the pathology report came in. Let me see what happened and what's the result of that. Um, so just know as you're reading through these results, you're going to want to start to get acquainted with the terminology. We have an entire module 101 that's dedicated to terminology, and I teach you all about word parts and pronunciation and what they stand for and how to group these together. Um, so just know that that's something that you will constantly be learning and adding to your vocabulary as you're starting to especially decipher medical notes, charting notes, and things like pathology reports. It's going to look like a foreign language at first. And then when you start to learn the terminology, you'll understand it more. Just comes with time. I also want to address the responses that happen within the body to things like fever, inflammation, or even response to injury. Now, there are protective responses of the body to fight infection that can result from pathogens. So, for example, a fever. When an animal has a fever, this is an abnormal increase in body temperature, and it's caused by the release of pyrogens. There's actually 5 cardinal signs to inflammation. So, this is going to be heat, redness, swelling, pain, and loss of function. Now, I want to make this very clear that a fever is not a bad thing. A fever means that the body's immune system is reacting to whatever danger or threat there is, and they are trying to solve it. That is the body trying to fight it off on its own. Now, of course, fevers can get dangerous when they get really high and the body's unable to fight something off on their own. That's when medical intervention and we step in. However, I want to make it very clear that a fever or even inflammation is not indicative of infection. Something can be inflamed but not infected, right? You could get an animal could have a muscle injury or some kind of osteo injury with their bone, and that's going to have a lot of inflammation from a certain injury like that, right? You're going to feel if let's say it was a knee injury, you're going to feel heat and maybe see redness on the skin. It could be swollen, painful. They might even not be able to walk on that leg because of, some kind of soft tissue injury, or osteo injury. But again, that doesn't mean that there is an infection present. However, if there is an infection, there's always inflammation somewhere in the body. So you can't have infection without inflammation, but you can absolutely have inflammation without infection. And that ties into the immune response. So we're talking about the natural protective mechanism of the body. The body will try to react and use its immune defenses against pathogens, against microorganisms that are foreign in the body. That is what the white blood cells are for. And we're going to start looking at that here. So there's specific immune defenses against pathogens in the body. We have a humoral response, and those are antibodies produced by plasma cells. Plasma is the more liquid portion, the protein portion of the blood. It's about 55% plasma, 45% red blood cells in our small animals on average. And they will actually transform into B lymphocytes. We might even have a cell-mediated response with T lymphocytes. Lymphocyte is just a type of white blood cell. So this is white blood cell responses to either defend the body against pathogens. They even send white blood cells to injury and trauma sites as well to help create that barrier and help repair. Can they always do it on their own? Not necessarily. And that's where that medical intervention comes in. But the body is going to have that natural immune response. And we're going to tie this into vaccines here in just a few slides as we start to look at zoonotic diseases. So, again, zoonotic diseases are diseases that are transmissible between humans and animals. So, your animal could give it to you, you could give it to them. For example, rabies is a zoonotic disease. We commonly see wildlife with rabies. So, for example, raccoons are one of raccoons, um, kind of one of the main ones that I can think about right now that are tend to be carriers of rabies. If a raccoon
Squirrels.
bites you, whether that's it bites your dog or bites you as a human, you absolutely are at risk for getting rabies. So that's one of the zoonotic diseases pops right off the top of my head. Tetanus is another one. Um, Also, any internal parasite is zoonotic. You absolutely can catch parasites from your animals. I have seen it countless of times. Um, and we will look a little bit more with parasites, but I want to hone in on that for a second because, again, we want to monitor and make sure that we are, when animals come into the clinic, we are watching out for zoonotic diseases and monitoring for things like zoonotic disease because that will elevate the human risk, right? So we want to hopefully develop prevention of this and control of these zoonotic diseases. Zoonotic diseases can be epidemic, which means they're epizootic. They could be endemic, which is enzootic. Um, Again, just different ways of modes of transportation there. With disease transmission, we have to identify things like reservoirs and host of the disease. And this is where I come into talking about parasites. You can get parasites directly from your animal. Absolutely. And I've seen it happen, especially if you're someone that likes to sleep next to your animal. And a lot of owners do, especially with animals that can go indoor, outdoor, you have a higher risk of transmission. There's a few different ways of transmission. There's direct versus indirect. So, direct transmission would be your dog has parasites, they slept in your bed, and bodily fluids, things like that, got all over your blankets, got into you, and now, boom, you got it directly from your animal. But there's also indirect transmission. Okay. This is transmission that involves intermediaries. So, for example, your dog, let's say they were, I'm trying to think of a off the top of my head. Well, if they did have rabies and it wouldn't be airborne, but that's not a good example. I can't think of one off the top of my head. I could pull up a whole list of zoonotic diseases, but let's say we have one that's airborne. Just give an example. Let's say it's airborne. So anything that's airborne, when that dog or cat coughs, there are microscopic water droplets that go into the air. When an animal coughs, it's safe to assume that that 20 to 30 feet in front of them now is contaminated with those water droplets. So indirect transmission could be the dog or cat coughs and you just happen to walk through that air that has those water droplets and boom, now you have it. So you didn't even have contact with the animal, but you still got it through an airborne transmission. It could also be vector-borne or vehicle-borne, and we're going to look at that here in the next few slides, what that means. To be a vehicle versus vector. It's Oh, sorry guys, I went a little bit too far there. Let's go back here. That being said, a vehicle or a vector. A vehicle is something which we will talk more about this. I want to preface by saying this really quick. We will talk so much more about internal and external parasites. We have an entire module that's dedicated to diagnostic testing, which includes blood, urine, and fecal testing and cytology testing as well. So in module 106, that's our diagnostics module, I have an entire PowerPoint that's dedicated to internal and external parasites, talking about the transmission of them, how to treat them, what are the symptoms, all of it. So do not worry. I know that we're kind of just lightly touching on some of these subjects today. You may have already taken 106 and you know what I'm talking about. If you haven't yet, don't worry. I have future modules for you that will continue on with these topics of discussion. So to bring it back in here really quick, a vehicle borne. So this is indirect transmission through an idimentary, like a flea. So for example, fleas 99.9% of time carry tapeworms. So if an animal has fleas, it is safe to assume that they have tapeworms as well. They didn't get tapeworms because they had direct contact with the tapeworm. They got tapeworms because the fleas that bit them and jumped on them had tapeworms and gave it to them. It could also be vector borne, which is, for example, leptospirosis is a great example of this. Leptospirosis is actually a blood infection that can happen and it's usually found in stagnant water puddles, out in nature, out in hiking in the soil. So stagnant water and soil absolutely can also be an idimentary, where if you have contact with that infected stagnant water or contact with that infected soil, you or your animal could very easily get and contract that disease. So it's not even having contact with that animal. You absolutely could get it just from being in the environment, which is why I talk so much about preventative medications, and the importance of giving preventatives, which we'll come back to that in a few slides as well. But that can prevent all of that from happening. Now, looking at zoonotic disease, I want to look at a few different kind of maintenance of disease or types of zoonotic disease. So there's direct zoonoses. That means that it's transmitted by a single vertebrate species. There's cyclozoonoses. That's several cycles of disease, usually parasitic, that occurs in several vertebrate species. There's metazoonoses, which is a disease maintained by invertebrate and vertebrate species. And then there's saprozoonoses, which is an inanimate reservoir that maintains a cycle of infection. So, for example, that stagnant water that holds leptospirosis, that's a saprozoonosis. It's not even an animal, it's an inanimate object, for example, like water or soil, that holds that reservoir for this infection. Now, when it comes to what should you focus on memorizing, I really just want you to know what a zoonotic disease is and about transmission of it and how to keep yourself and your animals safe. That is really what I would focus on here. Now, how do we control zoonotic diseases? Well, that's based on how we control the reservoirs and inventories. So, how do we control the animals that could spread it or the places that could also give it to you as well? Animals can be sentinels for potential epidemic or outbreak in people. There was a huge scare with COVID because they thought maybe it was going to be transferable as well. Thank goodness it wasn't. And the research is very gray area on it. By the way, I know that there was some big cases and stuff during 2020 of, gave it to their dog or something like that. A lot of the data was inconclusive, absolutely inconclusive. But if you could imagine, what if our dogs and cats could have gotten COVID? How much of a greater scale would that have been? That pandemic it just would have been at a scale that we couldn't even believe. So thankfully it wasn't zoonotic, because as you can imagine, we would need to be really on top of controlling that. So that being said, there is, we do have associations that are employed for disease control, CDC. Their main job is that's the Center for Disease Control. They control and monitor disease outbreak in animals and in humans, and that includes zoonotic diseases. So they come out with new protocols and rules, regulations that we need to follow to minimize it. So, for example, this happened recently in Washington, kind of in the Pacific Northwest, and it happens quite often, honestly. Probably it's like a once a year thing. Um, the equine, it's EVH, equine, it's essentially a herpes virus, but it's herpes in horses, similar to herpes in cats, which is feline viral rhinotracheitis, um, which is something that we vaccinate for. That's part of the FVRCP vaccine. It's not what when you think of herpes, a lot of people think of like genital warts. It's not the kind of herpes I'm talking about. In animals, specifically in cats, but also in horses with the EVH, it's a respiratory illness. Right now, there was a massive outbreak in EVH in the Pacific Northwest, and I follow that because I have family and horses that are up there. And horses were having to quarantine. They weren't allowed, they were canceling shows all over the region because they didn't want it to spread further, and that's the CDC. So they don't just watch human medicine, they watch it all. In fact, people that work for the CDC are people that have degrees in public health. Public health is disease management for humans and animals. So we see massive influence from them, especially with disease control all over the place, especially in the veterinary field. Now, one thing to keep in mind is with anything, some people are higher risk for zoonotic disease than others, right? Children, elderly, somebody that's immunodeficient or immunocompromised, right? They don't have much of a built-up system if they're a child. If they're elderly, they also could have a damaged immune system. Anybody that's in those categories is at much higher risk of getting a zoonotic disease, especially from like an intermediary, versus somebody who might have the immune system to battle it off on their own. So that is something to consider. If you are immunodeficient, you'll want to make sure that you are following really proper protocols, gloves, masks, and really protecting yourself. That's why I always say to wash your hands and to really, really be clear about it. I'm somebody that's immunodeficient, so I have to be really careful too. It doesn't mean that you can't work in the field. You just need to have extra precautions because your immune system might not react as well as somebody else's, um, to help you get through any type of disease contraction. Okay, next subject that we're going to look at this evening, and we're kind of just going to overview this because we've talked a lot about vaccines in this module. We had an entire vaccine PowerPoint. We talked about it in your chapter 8, and now we're just going to kind of overview it here. So I'm just going to kind of glide through the next few slides here through our vaccines, as an overview. So vaccinations has to do with immunity. There are different types of immunity. There is passive immunity and active immunity. Passive is vaccination. That's where the animal acquires performed antibodies, preformed antibodies. This is when we give them the injection of the vaccine. That's the antibodies. Their body becomes acquainted with that, and then they're able to fight it off naturally if they were to get that disease. Active immunity is when an animal develops it on its own. So it develops its own antibodies to the pathogens. So, for example, if you got COVID, your body develops those antigens or antibodies so that if you were to get it again, it's probably going to be way less severe and you're going to get over it a lot quicker. Same thing. If you got the vaccine, you're going to be in the same boat as somebody who already has the antibodies. You're just going to be giving them to yourself before contracting disease or preventing it entirely. So that's just an example. That being said, for vaccinations in animals, most of the vaccines that you give small animals are going to be administered via injection. We give subcutaneous injections for dogs and cats. If you're giving injections or vaccinations to horses or livestock, it's going to be intramuscular, IM. And that's usually given in the trapezius muscle in the neck or in the gluteal muscles in the hind end. We do have some vaccines that are oral and intranasal as well. Now, to reiterate, vaccination does not cause disease. What it does is it stimulates the animal's immune system to produce those antibodies so that they can protect themselves against that disease, hopefully never contract it, or if they do, they can fight it off and it's not a problem for them. Now, vaccines can be manufactured and marketed differently depending on what vaccine it is, the manufacturer that produces it. So there's different particular antigens that are unique to that pathogen. So, for example, there's modified live vaccines, which include a weakened version of the pathogen for that exposure. There's inactivated vaccines, and this is whole killed pathogens or selected antigenic subnets. So it's going to be the pathogen that's not going to be able to infiltrate. It's going to be killed. So they still get familiar with it, but they're not going to, again, minimal chance to that zero of getting contracting it themselves. It's already killed. There's also recombinant. These are the most common vaccines that we give. These are live vaccines. They're non-pathogenic though, into which the gene for a pathogen-related antigen has been inserted. So again, recombinant is one that we're going to deal with a lot, considered to be live vaccine, considered to also be the most effective. You might also see the modified live, very common in animal medicine. Now, let's talk about vaccinating. Should we vaccinate? That all depends on so many things. What I want to preface this by saying is there is currently one required vaccine that all animals must receive in the United States in order to receive veterinary care, and that is the rabies vaccine. That's required, that's non-negotiable. All animals have to receive it, and the reason for that is because it's zoonotic. And could you even imagine if there was an outbreak of rabies? I couldn't even imagine. So again, absolutely required, non-negotiable. You have to give rabies. But there's quite a few other vaccines. Again, we've talked about that in previous lectures. For dogs, we have DHPP, Lepto, Lyme, Bordetella, which is also kennel cough. For our cats, we have FERCP, FELV. So we look at a few different things when vaccinating. We look at what's the risk of exposure to that pathogen. There are core vaccines and non-core vaccines. So really quick, I want to just hone in on this for a second. So core vaccines are vaccines that are recommended for all animals of that species. Non-core vaccines will depend on the animal's lifestyle. And this is really how I would recommend vaccines. For example, dogs, the DHPP vaccine, that's going to be our main, that's our parvo, distemper, adenovirus, hepatitis. Um, that being said, that's the core. So DHPP, that's core. We're going to give it to every single dog, regardless. Why? Because honestly, parvo and distemper are massive killers. And if a dog gets it, the survivability rate is very low, especially if they're a puppy. For cats, we always give the FERCP, that's core, that's feline viral rhinotracheitis, calicivirus, and panleukopenia. That is also a core vaccine. We give it to every single cat because of the feline viral rhinotracheitis. Remember, that's a form of feline herpes. That is a respiratory illness that absolutely can kill kittens, and it spreads like wildfire. It very, very easily spread, very contagious. It's an airborne illness. So that's also a core. Non-core are going to be all of the rest of them. So with our dogs, that's Lepto, Lyme, Bordetella. With our cats, that's going to be the FERCP. So let's go back to talking about vaccines and why should I vaccinate or not? So core, to me, core is non-negotiable. You should always give those core vaccines because there's reasons for them. They will kill your animal if they get those diseases. That's why we vaccinate for them. So I would always recommend the core vaccines regardless. But when it comes to non-core, that's when I would look at things like what's the risk of the exposure? If I have a cat that is completely indoor, doesn't go outside at all, they have close to zero risk of ever contracting FELV. FELV is feline leukemia virus. The only way that they can get that is if they have contact with a cat that has it as well. If the cat is indoor, outdoor, or outdoor only, and they could be having contact with feral cats, absolutely they're at risk. But if this is an indoor only cat that doesn't see any other cats, ain't going outside, never, The risk is really low, and I would not recommend that vaccine for them. Unnecessary. Same thing with dogs. If we had a house dog that doesn't go on hikes, doesn't go on outside very much, uses potty pads, maybe they're an apartment dog, high-rise apartment building, I probably wouldn't vaccinate for lepto. The odds that they're going to take that dog on a hiking trail and come into contact with it is really low. So I always look at things like that, risk of exposure, when selecting if we should vaccinate for non-core or not. We also want to look at things like the cost of the vaccine, the benefits of the vaccine, um, and the effects of the disease that are caused by that pathogen. Again, I always recommend, again, DHPP, that's like non-negotiable because parvo is so deadly. So deadly. So is distemper. Versus lepto, they can survive. It's would be a horrendous treatment, but they could survive it. Bordetella is really easy to treat. So, looking at things like that. There is something that I want to note. I know that I've talked about it in previous lectures, but we do have to be careful about the association between vaccines and vaccine-related sarcomas in cats. Sarcomas are cancerous mass that can develop in cats post-vaccine. I talked about this a lot in my vaccine PowerPoint. It has to do with whether the vaccine is adjuvanted versus non-adjuvanted. They've done a ton of research on this, and they've now come out with non-adjuvanted vaccines that do not cause the sarcomas because they found out through research that it was the adjuvants that were causing them. So they removed the adjuvants, and they created a brand that's called PureVax. And it's non-adjuvanted vaccines, and they're the safest vaccines that you can give to your cat. They are pricier. They're $60+ per vaccine, but you are guaranteed pretty much through that research that your cat will not get a cancerous mass post-vaccine. And this is also why we tend to vaccinate lower down on the legs, so that if a sarcoma did happen, we can amputate, just that portion of the leg, and the patient could survive that. But this is something that's been in the works for years and years. Sarcomas, they saw that way back in the 90s. And they've had the adjuvanted and non-adjuvanted, the research for these vaccines for a while. It was back in the early 2000s, 2010 era, kind of when I was first getting into the field, where they really started to come out with PureVax and start to use them. Now it's pretty standard. I don't know any veterinarian that's still giving adjuvanted to cats because it's just too big of a risk. Now, vaccines are oh, sorry, we looked at this one, core vaccines versus non-core vaccines, tying into kind of how would I weigh whether an animal should receive it or not. This is just a list of available vaccines for dogs. I also have a list on here of available ones for cats. Again, I've already talked through all of those ones, what's available, what's not. I will say that there's one on here that isn't available on the market anymore. So FIV, that's feline immunodeficiency virus, we don't vaccinate for that anymore. The reason being is that the vaccine was causing false positive test results when testing for FIV post-vaccine. Um, so they had to pull it off the market. It's been in a lot of research for at least almost 10 years now. They've been having it back in research, and I'm really hopeful that within the next 10 years, we see it come back out to the market. FIV is the feline equivalent of HIV, human immunodeficiency virus. Yes, so FIV is a sexually transmitted disease for cats. We see it a lot in feral cat communities. And FIV, just like HIV, it causes the immune system to be suppressed. So someone with HIV could get the common cold and die. Same thing with a cat that has FIV. They could get feline viral rhinotracheitis, which is very treatable, but it could kill a cat that has FIV. So they've been doing a lot of research though in human medicine. You may have seen some commercials for pills and even injections that they're giving for HIV treatment. So cool and preventative for HIV. Incredible. Veterinary medicine is about 10 steps behind human medicine, so I'm really hopeful that because they're making so many advances with HIV, that we see more advances with FIV. That's my hope within the next 10 to 15 years as we see it come back to the market, and we see that it's effective because it could be so beneficial, especially for like TNR cats, trap, neuter, release, feral cat colonies, so beneficial for that. Now, there is options with antibody titers instead of vaccination. Now, the odds of somebody doing a titer versus a vaccine is really low because vaccine titer blood tests are expensive. The only time that I've ever ran vaccine titers was because of travel. So if a animal is traveling internationally or if they're going to Hawaii, they have to do a rabies favin antibody titer test. This test will test for the amount of immunity that this pet has, or the measurement of antibody titers to that disease that they're vaccinated against. So when you vaccinate for rabies, for example, you have to get this titer test. I had to do it for my cat when I moved back to Hawaii. Um, they have to be fully vaccinated for rabies, and then you do this titer test, and it takes about 4 weeks to get the results back, and it's about $500, $500 to $600. It was pretty expensive. um and it will tell you if the vaccination has been sufficient and if they are sufficiently vaccinated for rabies and they have those sufficient antibodies in their system. This is important because Hawaii has never had a single case of rabies on any of their islands, and they don't want it. And same with a lot of international countries. So it's all about disease prevention. So what the Favin test does was what this rabies antibody titer does is that you can bypass quarantine by doing the titer test. So if you travel to Hawaii with an animal and you don't do the antibody titer, you have to quarantine them for 180 days before they release them to you. And you have to pay for them while they're in quarantine. That's a few $1,000s. Versus you can run the antibody test on them if they've been fully vaccinated for about $500-$600, and then you can bypass all of the quarantine. So again, you're more than likely going to see these titer tests for health certificates when someone's going international or if they're moving to the islands. And again, it's commonly done because we're trying to prevent disease transmission and prove that that patient has been sufficiently vaccinated. Pretty expensive, but again, it's worth it. For me, it was completely worth it. I didn't want to quarantine my cat. I wanted her to go straight from the airport home with me. So, for me, it was completely worth it. And in all honesty, if I were to add up how much money I would have paid to quarantine her over the titer test, I probably saved several $1,000s by doing that. So it will be something that you'll see every so often with those travel certificates that they might need to do a titer test as well. Now, when it comes to preventative medicine, we were just talking about it. Vaccines are a part of preventative medicine. But what's also a part of preventative medicines are things like anthelmintics and parasitides. So I'm talking about antiparasitics, I'm talking about monthly preventative medications. We have monthly preventatives for fleas, ticks, heartworm, and other parasites. So these are monthly medications that you can give topically or orally to the pet to prevent those things from happening. And remember, fleas, ticks, they harbor disease. Fleas always have tapeworms. Ticks can have Lyme disease. If the animal's not on a preventative, they are at risk of contracting a disease from that intermediary, right? From the flea, from the tick, or more disease and infection from internal parasites. So we always recommend to put animals on preventatives. Absolutely. Especially depending on the area that you live in. Southern California is warm all year round. It doesn't get that cold. So that means that fleas and ticks don't go to sleep. It's not like the Midwest where it gets, frigid and below sub-zero temperatures where those type of parasites you're not going to see. So in Southern California, many of you will, start working at hospitals here in Southern Cal. You want to keep that in mind, that preventatives are pretty non-negotiable here. You absolutely should be giving them, especially in warm weather climates, because those parasites, especially the external ones, they're not going anywhere. There's no dormant season for them in California. The last topic we're going to look at this evening before we're all done is factors with predisposing to disease. So What are physical factors or things with your animal that would predispose them to getting diseases? There are some controllable factors, but there are factors that are also not controllable. And we're going to take a look at that throughout the next few slides here. So, genetic factors is a huge one. Mostly genetic factors aren't controllable. Why? Because that's just part of your genetics, that's in your bloodline. There's not really much that you can do to fight genetics. But we can reduce predisposing factors by selective breeding. So, for example, if you had a dog that had hip dysplasia, you don't want to breed that dog because that offspring is likely to carry on that trait of having hip dysplasia. So, if we have selective breeding, and this is why there's such a massive business for purebred breeders and all of that across the United States, is because that selective breeding, they will select the best they will select the best parents for these animals to have the most ideal offspring, right? So they're going to select parents that have good traits, ideal traits that don't have medical conditions, because who's going to want to buy a puppy whose parent had hip dysplasia? I wouldn't. You're just asking to buy a dog that's going to be thousands of dollars in medical bills. So that's something that we can actually somewhat prevent with really good breeding and also doing research. If you are going to spend money on a purebred or going to a breeder and buying a cat or a dog that is, again, spending quite a bit of money on them, make sure that you ask for things like x-rays and fully vetted vet reports and making sure that they are genetically sound to be bred so that you're not buying a puppy or a kitten that's going to have a ton of medical problems in their life. Now, we also see other genetic factors. There's gender predispositions. So, for example, females are going to be prone to medical conditions versus males will be prone to others. And that has to do with their hormones, their reproductive systems, and so forth. We talk a lot about that in our anatomy module, Module 101. There's also inherited mutations, again, stuff that gets inherited through the bloodline. There's immunodeficiencies that can be inherited. And inbreeding can have a really big effect too on genetic abnormalities in animals. Again, making sure that you're getting your animal through a reputable vet checked breeder is going to be the best thing that you can do. Obviously, if you're adopting, you're getting them from a shelter type environment. Very limited on kind of things that you can do there to make sure that the dog isn't predisposed. But just something to put out there. Now, we also have to look at dietary factors. These are mostly controllable. When it comes to what you feed your animal, you absolutely can control that. And I'm talking about the type of feed, the quality of the feed, the quantity of the feed, and the feeding regimen. Poor dietary factors lead to stress and increased cortisol, increase on the adrenal glands, absolutely can cause a myriad of health conditions. Which again, we have an entire lecture talking about the endocrine system, which is the adrenal glands are a part of that. And we talk about the effect of oxidative stress on the body and all of the for example, hyper and hypoadrenal Cushing's, Addison's, what can happen when overly exposed to stress. And diet can be a huge factor that's silently stressing your animal. So again, making sure that you're feeding them a diet that is reputable, meeting their requirements for their energy producing and non-energy producing nutrients, and matching it to your animal's activity level is very important. Last slide here, looking at the predispositions to disease. There are environmental factors, which not controllable. You can't control the weather, but you can control the housing, right? You can control the environment that your animal lives in, whether they live in your house or outside or have a doggy house or whatever it is. Pretty controllable for those housings. We want to make sure that they're housed appropriately. Animals that aren't housed appropriately, or if they're in poor conditions, that leads to, again, more stress and possibly pathogen proliferation, right? They can get exposed to pathogens, diseases, parasites, all sorts of things. Um, so we just want to be aware of that and keeping them in good conditions the best that we can. There is also metabolic factors. There are metabolic factors that aren't controllable, right? You can't control the age of an animal. You can't control if they've had concurrent diseases and things just happening one after another. And you also can't control their reproductive status. But things that you can control with their metabolic factors are things like obesity. We talked so much about obesity in part one, with feeding appropriately and how obesity is linked to really all-cause mortality, and health conditions in animals. We also can control the amount of exercise our animals get. And again, going back to proper nutrition. Exercise, nutrition, that's the core foundation for any living being. And things that we want to keep in mind, absolutely things that we can control and improve on with our animals. All right, class, that's it. We're at the end of the slides. Really quick, I want to show you on the last slide of this lecture, it does have a version of a body condition score system. So we use these charts. We talked about this in part one with body condition score and how we know if an animal is too thin, ideal, or if they're too heavy or overweight. We use a body condition scoring table that looks just like this. This one's from Purina, but this is just an example of what one would look like. So your veterinarian is going to use a charting system like this to grade that animal based off their body composition to know if they're, again, underweight, of ideal weight, or if they're overweight. So you'll see this, and you'll probably see this in your labs as well. Something that your veterinarian will use constantly. And we love to use the images too, because we'll talk the owners through this to help them understand, again, to get their patient and their animal into that peak physical health. Because if they are physically healthy, they're in that ideal range, the risk of disease drops significantly. And that's our whole goal. We want to prevent diseases. We don't want them to happen. We want animals to live long, healthy, awesome lives. And a lot of it comes right down to those metabolic factors. Okay, class, that's it for the PowerPoint. I am going to end the recording here.